and the fibula ligament. Her case, right? Her case, 2 millimeter. So the ligament is smaller than 2 millimeters. Right, okay. Mine is 4. So the ligament is about 3. So it's okay to observe. But, okay, let's repeat again. LCL, right? Find the LCL. Heel walking and move forward slightly. Bicep femoris. Okay. Yes. And popliteus tendons. Find the popliteus tendons and start from the fibular head. It's popliteal fibular ligament. This is very, very important ligament. But if you invite me next time, I will show you. Thank you. No, I was kidding. The probe is not very good. Okay, try this. Try these 3 first. 1, 2, 3. And the meniscus. 4, 5. Fibula. Fibula. Okay. No. 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 Don't cry. We don't need the fibula. I need the fibula here. Yeah. Fibula is correlated to the strength of calf muscle. Strong calf muscle often has a fibula. Okay, suckers. No, twice. Next one. Or you can invite the girl. She has 2 millimeters fibula. No. The LCL ligament, right? Popliteus. This is dark. Why this is dark? Because when I was a student, we don't really know the orientation of the probe. We only look at the border. And someone suggests, no, we have to have a stand-up procedure. The orientation of the probe, the distal sign has to point to the fibular head directly. This probe is 5 centimeter probe. So you can see the femoral condyle, sulcus, and the fibular head in one imaging. Okay? The probe you use is less than 4. Not possible. So you have to move the probe to the fibular head. So they use very good machine, but the skill is not good as you. So the pictures looks like this. Dark. But you know the LCL is bright. The popliteus tendon is dark. If you look at this imaging, you find there is a tiny artery here. Tiny artery. And if we have time, we can try arcuate ligament right above the artery. Some people have very strong arcuate ligament, and ligament press the artery, cause symptoms. The reason why we need to address this, because around 2000, the year of 2000, my supervisor suggests raised an argument. He suggests that physical therapy or sports medicine personnel need to look at, or specialists need to look at the posterior lateral corner instability or disorder. And he asked me to check the student's response. And the student's response was very poor. No one listened to him. That's normal, right? When we talk to the student do not give up, so it's normal. But now, it is very important topic. The important top structures in the posterior lateral corner include LCL, popliteus, popliteofibular ligament, and arcuate ligament, and also PCL. So, we need to use ultrasound to check these one by one. Find the fibular head, move anteriorly and use the heel walking scale. You find the bicep femoris tendon, very thick, very strong, very thick, very strong. If you move the probe upwards continually, you will find the iliotibial band. Iliotibial band is very easy to find if you are interested. This is an example of iliotibial band freezing syndrome. There are a lot of fluid surrounding the band. Okay. And the triangle shape is not perfect triangle shape anymore. There is a gap inside. And the gap can be observed more clearly when you're doing the internal rotation. Yeah. Thank you. Okay, the popliteofibular ligament. I will try later. But I'm not guaranteed. But fibular ligament. I think some of them in this room some of us in this room does not have a fibula, right? But you got a fibula, 4 millimeters. Yes. But we will try with the machine. Then we look at the arcuate ligament more. Basically, it's not difficult at all, easy. But you don't believe me because I have been seeing easy for the old days, but you feel frustrated. Find the LCL, easy, right? Please, suckers, popliteus. I told you, move forward and use heel walking scale. Find the bicep femoris. And move forward, find the iliotibial band. Okay. Move downwards. You can observe the arcuate ligament. Arcuate ligament basically are very invisible. So we use the artery. to help us to identify the accurate ligament. As long we noticed yesterday in the shoulder joint, some participants, their suprascapular artery does not show pumping in the ultrasound, right? But we can try, but not guaranteed. Okay, then we are going to close. We are going to introduce some structures. Then we are going to close our class today. There is a, yes. In Taiwan, okay, we begin from the medial side or lateral side. Either way is okay. If you begin from the medial side, if you begin from medial side, at the knee level, medial condyle, okay, the level corresponding to the level of medial condyle, you find a huge mass, head of medial gastrocnemius, and three spots. This is very easy to find. Transverse view. This is very easy to find. 3 spots, a dark point, a bright point, another dark point. Semi-membranes, semi-tendinous, okay, and the sartorius, SGS. Easy. Because this is very, very easy to find. If there is a fluid inside, ladies and gentlemen, Baker cyst. So, as long as you, but sometimes personally, if I check the medial collateral ligament, I will ask the patient to prone, then same level, right? Because we found the medial collateral ligament start with the medial condyle. When they get prone, same level, look at it behind. Yes. And if you start the back knee from the LCL, it's the same. From the lateral condyle, and ask the patient to prone and check the level. So 4 structures. The easy one, dark one. Dark is very easy to identify. So in order to see something dark, we need to reduce the dynamic range, right? So are you going to need the help from Mahito staff, or you want to do the job by your own selves? No, just press the button, reduce the dynamic range to 90. Let them do the job. If they do not do the job very correctly, we will shout, "I told you." Okay. Reduce the dynamic range to 90. I told you twice, 3 times. Okay, good. And find something dark. Okay, above the medial femoral condyle. Okay, and 2 dark membranes, sartorius, 1 bright, tendinous, because it's tendinous, tendinous, bright. Okay, fluid between semi-membranes, medial gastrocnemius, may indicate bursitis. Some people call Baker cyst. Okay. Good. You are totally confused. Good. Yeah, that's my job. this student has very poor skill. This student has very poor skill. Medial Geytroninius, head of medial Geytroninius, and there is a dark area here. Oh, there are fluid in here. No, where is the cortex line of the medial femoral condyle? No, so don't tell me you find something interesting. Give me an image with better quality. This is an example of Baker system. Or medial Geytroninius semimembranous bursitis. But if this cyst does not cause problems in deep squat, usually physicians does not do anything to this. They don't even use needle to inspirate the fluid out, because the fluid will go back, will come back again, and very quickly. Okay, if the patient is suffered from a big cyst, a big Baker cyst, some medical doctor may remove the cyst by surgical. Okay. Then, if we are going to, then we move to the center, medial. Then we move to the center of the back knee. There are one thing pumping, deep. So, in order to see something pumping, we need to reduce the persistence to 3. Because we used 7 or 5 before. Because the artery is pumping, right? But the pumping, the image of pumping are averaged by the persistence function. So we did not easily see the pumping of the artery because we increased the persistence. The reason for us to increase the persistence because we want to reduce the noise. So reduce the persistence to 3. 3 means one image present 0.1 seconds echoes response. Do that. Okay. Reduce dynamic range to 90. Reduce the persistence to 3. Okay, they are totally confused. Good. So we can keep shouting. Yeah, good. Okay. 3 things between the middle head, between the head of medial Geytroninius, head of lateral Geytroninius. There are 3 structures: pumping, vein, tibial nerve. Yes. Okay. Then moving. Oh, that's it. Okay, sorry. Right, I think I lost one slide. If you move the probe to the behind the lateral femoral condyle, you will see a bright spot Oh, very similar to this one. Yes. And behind the lateral femoral condyle. Okay. This is a panoramic imaging. So basically, the image is about this size. This size. So this imaging was combined by 2 or 3 imaging. Okay. Panoramic view. 1, 2, 3, 4, 5. Okay. So this imaging includes lateral femoral condyle, and this is the common peroneal nerve. Common peroneal nerve. Okay. So 1, 2, 3, 4. 1, 2, 3, 4. Can you see the honeycomb profile in the common peroneal nerve? Okay. Then the nerve will divide to superficial peroneal nerve and deep peripheral nerve that we are going to check and observe tomorrow. Okay, that's it. So I'm going to demonstrate again. So then I will let you practice from 15 past 4, and we are going to finish. Ask you to stop to practice before 5 o'clock, so everyone can pack and go home. Cool. Any questions? Any questions? No? Good. So the lady, she very good in kicking box. Yeah. Can you help me? The lady very good in kicking box. She right. Okay. Because I know this machine, the best range is about 1 to 3 centimeters. So I'm going to increase my depth and put the structure that I want to see in the between the zone zone. LCL, popliteus, no problem, right? Cool. Then move backwards. Okay. Okay. No one was listening to me. Okay, thank you. Let's try. You see the qualities become poorer, right? It's not as good as the first time. The two-layer structure is not so clear because we want to see the arcuate ligament and a tiny small artery. So we will try. We need to find the breeze first. Okay, still can be 2 structures. Okay. Move backwards. Pimenkong, Professor Pimenkong, can you help me? No, the artery, the pumping, the small one. No. No. Put your finger on the screen. Oh, lower. No. Lower. Yes. Upper. Okay, too much. Yeah, left. Okay, go. Your finger, go. Go. Move your finger. Okay. See that one? Yes, you're right. It's a tiny thing. Artery is here. That is the arcuate ligament. Arcuate ligament. Its artery is here. Let me do it again. Dun. Okay, I'm confident about this device right now. 2-layer structure, very poor quality. It's all right, because we changed the setting. Move backwards. Dun. Over here, it's pumping, right? Let me make the artery more better. The laser pointer is useless on the TV. Oh yeah. You did right job. No, not yet. Very close. Okay, I need to press a little bit. Yeah, cool, yeah. That's the ligament. That is the ligament, but artery is here. This is artery as well. It's pumping, right? Yeah, thank you. And this is arcuate ligament. It's pumping, right? Okay, I did my best. Yeah. Okay. Okay, no problem. So it's all right. We start from here, right? Okay. Then sulcus. Lateral femoral condyle. Fibula. Okay, fibula. Okay. Kicking boxer. Fibula, yes, thank you very much. Echoic shadow, 4 millimeters. The study in Korea suggests the strong calf muscle often observed with fibula. But the Korea study show 50% of Korean people do not have fibula. So does that imply Korean people have a weak calf muscle? I don't know. You get my point very quickly. Okay. Good. Oh, stop laughing. Maybe you are married with a Korean girl, right? This is common perineal nerve, right? Pumping, pumping, pumping. Popliteal artery. Move, keep moving, keep moving, keep moving. Right, Ben. Yes. Okay. Which one is the tibia nerve? I'm still looking for it. Okay. Decrease total gain. Okay. Which one got the profile of a honeycomb? It looks like this one. Looks like this one. Looks like this one. I'm not sure really, because I try my best. I put the focus wrong in here, right? Looks like this one. Looks like but I'm not sure really, but the best way to prove is move the nerve in the center of the window, then turn 90 degrees. Sorry, it's my fault. No, pillow. I cannot put my arm like this. No, it's rude. Yeah, thank you very much. Yeah, thank you, thank you. Sorry. Okay. So I can start again. Common perineal nerve, bright, right? Common perineal. Artery, pumping. This one, nerve. Then 90 degrees. Hey, so lucky. Yeah, distal is correct. Proximal is wrong. The location, focus zone is correct. So, here walking. Tilting. Okay, freeze. Good. Tibia nerve. Very similar to the medial nerve you saw this morning, right? I can do it. You can do it. Right, so come on, head of lateral gastrocnemius, common perineal nerve, and popliteal artery, popliteal vein, and the tibia nerve. Then we move to medial gastrocnemius, head of the medial gastrocnemius, and semitendinous, semimembranous, sartorius. Goodbye. Yes. sorry. Please remember, even the same genders, we need to prepare 2 pillows. Okay, so because I was looking at the screen, and this movement I did is pretty wrong, very, very wrong. Okay, in Taiwan, if she is unhappy, she can sue me. Okay, so I was too focused. It's my fault, because but it's my advantage because I'm so focused. So I haven't changed my wife yet. Okay, right. Hope my wife like this joke. Right, pumping. Right? Okay. Bumping. Then, sorry. Media conduct. Okay, we start from the okay. Oh, very, very bright. The common period, yes, very bright. Yeah, good, good. So this device is basically very good for 3.5 to 1 centimeters. Yeah, the probe we got is very good. Artery pumping, and we move to the medial quaternions. Okay, goodbye to the tibia nerve. Artery, vein, nerve. Then we move to femoral condyle. Medial. Hey, hello, head of medial quaternions. Right, easy, right? Then move lateral, medially. Hey, hello, semitendinous. Can you see that? Can you see? No? Because I don't want you to sue me, so I'm going to move the TV. Bright, right? Okay, but we are going to head of the medial quaternions. Okay, head of the medial quaternions. Then keep moving medially. Sartorius, semitendinous, sartorius, semi-membranes. Yeah. I will do my best again. Did you see this one? Semitendinous, right? Semitendinous. Medial quaternions. Medial quaternions. Try my best. Oh, that's better now. Medial quaternions. Medial quaternions, right? Dark area, semi-membranes. Bright semitendinous, dark area, sartorius. That's it. It's your practicing time. Wish you luck. Wish you my best. Yeah, and come back tomorrow earlier. And stay here for more than 1 minute. Okay. Side lying, please. Yeah. when I was, when I, sorry, can I do this? Okay, thank you. When I was, when I black hair, so my hair color is the same black like Ping Mong Kong. My university asked me a lot of publication. And I don't give a, but I need survival, right? So I wrote a letter to my supervisor. What should I do? Should I looking for a life that I really want, or stay at NTU, do something that I wish to do in the future? And then my supervisor answered me, you did not answer the right questions, but you did not ask the right questions. The question is, are you happy doing what you are doing? Are you happy with what you are doing? Okay. And I say, I don't know, can you give me suggestions? My supervisor say, okay, what makes you happy? So when I was in Mahido, I asked staff, what makes you happy? And use these to do your research. Okay, what makes me happy is I like to see people smiling. Yes, your smiling makes me feel energized. So my teacher say, okay, go some study, go have some study with imaging. And I'm so poor. I was so poor, and no one gave me a. So I borrow a machine. And I look at my student and look at my patient. One idea just come out. In 1964, Ober test is very common to stretching the IT band for the people have low back pain. But not a very famous researcher modified the mobile test and did not use his name, but renamed to modified Ober test. And I think, why not check the old modified Ober test is much better than the Ober test, right? So I wrote and I found that in gentle stretch, Ober test is no difference to the modified Ober test. But in strong stretch, modified Ober test is much better than Ober test. And I submitted to APMR. APMR, you know, if you write any article without patient, they will reject you in 1 minute, in 1 second. I think a lot of people in this room have the experiences. And the article was, I get a reply 2 weeks after from APMR. And the editor say, I like your article very much. I'm not a student of Ober. A student of Ober, another. And I have done some modification in your article already. If you accept this modification, you just click accept and reply me that you accept this modification, and I will accept your article. 2 weeks. 4 months after, the article is published. And my tears almost came out. Not APMR. APMR was in the top, now still is in top. Helped me to survival at NTU for another 3 years. So I have some more time to think of what I'm going to do. So you ask me to do the IT band, it's my pleasure. Change to the dynamic range, 110. We are very good in the setting. So we have to think about what we are going to look at, and make the necessary modification. IT band, the best way to observe IT band is from the transverse view. Because it is wide, it's bright. It's bright, right? It's bright, right? So we need to increase the dynamic range, right? Right? Increase the dynamic range. There's nothing about what I'm going to do in the slides, so you don't need to look at the slides. Hello. You don't need to look at slides. Yeah, that's my secret. Yeah, okay. Did you see the ovary shape behind me? That's the transitional area of the IT band. It's when it goes down, it divides to two. So one is ilia patella check, another is the ilia patella band. Ilia tibia check, ilia patella band. Yeah, the IT band become two. One insert to the patella, one insert to the girdle tubercle. That's why IT band is so important for patellofemoral syndrome. So which one is much better? Which one is much more important? The ilia patella check. Okay? Anterior one. So the IT band will become like two bundles. Two ovary shape. Okay? Find the lateral epicondyle. Lateral condyle. Find the ovary shape and keep. Okay, freeze. Come more ovary, right? Because Pimongkong may found I use heel walking and also rotate skill because it is curved. Okay, so this is positioning. Sorry. And can you lie on here? So your leg, can you, your back face to me? Yeah, you face to them. Yeah, that's all right. I think you are going to have no time to practice, but it's all right. I know you are coming tomorrow earlier, much earlier than before. So I expect you come here to practice tomorrow about 7 o'clock in the morning. Okay, thank you very much. I need Professor Pimongkong to help me to fix her pelvis. Yes. Yeah, okay. Right. This is the cross-sectional area of the IT band, right? Okay. Become smaller, right? Narrow, become ovary. Flat. Ovary. Flat. ovary. See that? Okay, cool. APMR. Really? Yeah. And another, modify over test. Sorry, I need to do it again. Chill. Thank you. Yeah, thank you. Okay, good, better. Because the gel is nerve, so I need to put the IT band in the bed in a good focal zone. Okay. Start to stretch. Become narrow. Ovary, 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 ovary. There are two bands, right? Okay. If you are not very good, I can move the probe slightly higher. Okay, that's the cross-sectional area of IT band. It's wider now because the level is higher. So you found that the anterior, which one change most? The tail or the head? The head is the left side. The tail is the right side. Okay. Can you tell me the head change more, or the head change more, or the tail change more? Which one? Tail. Tail, the tibia check. Two bundles, yes. But I didn't differentiate the two bundles in my study. I just used one. But now, sorry. Okay. Can people help? Yeah. You hold the probe, of course. Okay. So I didn't differentiate the iliac patella band, iliac patella check, and the iliac patella band and the iliac tibia check. I didn't differentiate. I only compare the total width of the band is reduced during the stretching. Okay. That's it in my personal study. Yeah. That saved me for another 3 years to survive.